Good morning. It's 8:04. I'm sorry we're late. I'm told that there's a huge throng on the Zoomosphere, so welcome. This is kind of fun because it's the last grand rounds that I'm going to preside over as chair. So I'd like to thank everybody for participating in academic enterprise at a very busy clinical place. It's hard to it's hard sometimes to pay attention to things that aren't involved in the practice of medicine when we're so busy, but I think it's what makes us special, and I think it's what's really one of the best things we could do for posterity is to improve, both the way we practice medicine through scholarship and also teach the practice of medicine to trainees. So I want to thank everybody who's been involved in that, and I'd encourage you to continue it. I think it's a very worthwhile endeavor. Today, I've got the extreme pleasure of introducing one of my colleagues in gastroenterology who's going to give grand rounds this morning. Dr. Colloon joined us, it was about 8 years ago, about 9 years ago. Came to us from out of training where he was at the Indiana University, which was one of the preeminent gastroenterology programs in the country. He trained before that is, in my opinion, at the premier internal medicine training program in the country at the University of Pittsburgh, or UPMC. He's also a graduate of the Aga Khan University School of Medicine in Pakistan. He's, like I said, he's been with us since 2012. He's become the chief of gastroenterology here at Erlanger Health System and the Division of Gastroenterology at UT College of Medicine in Chattanooga. He's become an expert in several endoscopic technologies and actually has become one of the worldwide leaders in the pioneering the use of artificial intelligence and AI technology for detecting polyps. We're one of the few centers in the country to be experimenting with that. So without further ado, it's my colleague and friend, Arslan Colloon, going to give us a talk on colorectal cancer screening updates. Thanks.
Thank you so much, Dr. Lambiase. It's been a pleasure working here for the last almost 9 years under your leadership. Dr. Lambiase was the chief of GI when I was hired, so I've worked under his leadership and have learned tremendously from his experiences, his knowledge, and it makes us feel sad that he's leaving, but that doesn't mean that we're not going to be in touch. But thank you so much for all what you've done for the Department of GI, for this institute, and hopefully we'll continue to build on your legacy in the Department of GI and the GI Fellowship Program. So thank you for the time that you've given us. I'd like to talk about colorectal cancer screening today. It's a topic that seems quite redundant, for a lot of internal medicine specialists, since this has been a topic that has been out there for very long. But there has been some recent changes that I thought were very interesting that we should, go over just to kind of give us an idea as to which direction things are moving in colon cancer screening. So let's, before too late, get into this. So the agenda for today's talk, we're just going to talk about a few facts. It's going to be a very simple presentation. We're not going to talk about, a lot of complicated statistics. We'll just talk about simple facts, some data related to colon cancer. We will touch upon the topic of when to start screening, and we'll go over some historical data that led to that age point. We'll talk about various options that are out there and what goods and bads they have. And then we'll delve in very briefly into some of the new technology that also briefly Dr. Lambiase alluded to, what is coming on in colonoscopy. So no disclosures related to this talk. Now, I think, these are the questions that I think all of us should be asking ourselves and our family members, just to kind of know a little bit more or pay a little bit deeper attention towards colorectal cancer. So these are the questions that, American Society of Gastrointestinal Endoscopy suggests that, could actually save your life or someone who knows their life if you know them really well. So let's go over through them. We don't have clickers, otherwise we could have taken a poll. But let's go over the first one. So colorectal cancer screening is predominantly a man's disease. That's a common understanding in the community, that it's a man's disease affecting many more men than women annually. What is the take of the audience? What do you think about that fact? Is that true? Is that false? Good. So I'm glad that, most of people think it's false. Yes. So this is a disease that affects men and women equally. There's a higher proportion in men with colon cancer, but, it is a disease that affects both men and women. So it's not predominantly a man's disease. It involves both genders. The next question, only people over the age of 50 who are currently experiencing some symptoms or problems should be screened for colorectal cancers or polyps. True or false? So that's a glaring false. One, there's a few things that are changed, but any person who's experiencing any symptoms related to bleeding, changes in new bowel habits, or weight loss, which is unintentional loss of appetite, is someone that should be looking into figuring out if they might have colon cancer. Polyps may not present with symptoms, but again, there's a reason that we screen for people sooner than age 50. So this statement is also false. Next statement, colorectal cancer is the second leading cause of cancer death among men and women combined in the United States. What do you think about that fact? So that is true. So it is the second most leading cause of cancer death after lung cancer in this country. So it's a huge problem. We don't think of it as seriously because, we have good tools to prevent it. And that's what we've successfully done over the years. But it still is the second leading cause of death from cancer in the United States. Next statement, tests used for screening for colon cancer include colonoscopy, fecal immunochemical test, FIT DNA or stool DNA test, FIT-based fecal DNA test, flexible sigmoidoscopy, and colonography. Do you think all these tests are tests that could be used to screen patients for colon cancer? Very good. Yes. So all these tests actually can be used. So it's not just colonoscopy that is widely considered to be the test, but it's still maybe the test of choice. But there's other tests that could be available that could be used to screen for colon cancer. Colorectal cancer is often preventable. Yes, so that is going to be a huge part of this talk. Yes, this is a preventable cancer, unlike some of the other cancers that we see that generally present very late during their course. This is something that we can prevent if we're looking for it, or if we're being conscious about looking for patients with cancer. So this is definitely a preventable cancer. So more of the reason that we need to know more about this, so we can actually prevent this in people that we love or in ourselves. So if you look at the relative risk of patients, who develop colon cancer, so what are the big risks? So most of the cancers, have similar risk factors, but there's some factors that are unique to colon cancer. So family history of, let me just point this so at least people who are on Zoom can see that. Control and mouse. I don't know why that's not making it a pointer. Anyways, I'll just use my mouse. So family history of colorectal cancer definitely plays a big part in someone who can develop colon cancer. So one or more first-degree relatives at a very high relative risk in terms of having future colon cancer in someone. One or more first-degree relatives diagnosed before the age of 50 is a very strong risk factor. And if you have two or more first-degree relatives, that's a very significant risk factor for colon cancer. Similarly, if you have one or more second-degree relatives, it still exudes some risk towards colon cancer, but it's not as much as first-degree relatives. Also, a lot of times we forget, adenoma, which is a precancerous polyp, can be a risk factor even if it's in the family, towards colon cancer risk. It just may not be as high of a risk, but somebody who's had a precancerous polyp in a first-degree relative, that's a strong risk factors for developing colon cancer. Inflammatory bowel disease, just by the nature that, there's chronic inflammation, any inflammation leads to more cancer, so that is a risk factor. Interestingly, type 2 diabetes has been looked to be an independent risk factors for both men and women. No, not a huge risk factor, but insulin resistance has been shown to be related to colon cancer incidence. Some modifiable factors, lifestyle, definitely affects that. heavy alcohol use, more than 3 drinks in a day. Obesity, both in men and women, has led to colon and rectal cancer. These are all modifiable factors. Red meat consumption greater than 100 grams per day, especially processed meat consumption, smoking, even if they've been a former smoker versus current smoker, that all leads to increased risk. Off note, physical activity and dairy use actually has been linked towards colon cancer. If you've been active, that is preventive. If you're taking good amounts of dairy, which includes good calcium and vitamin D supplementation, that is actually protective. So that has been shown to be protective towards colon cancer. So these are some of the risk factors that people need to be aware of when thinking about colon cancer. Important thing, very, very important take home from this slide, colon cancer screening does save lives. It's a preventable cancer. If you get into this, if you pay attention, it can save lives. So close to 150,000 patients are diagnosed with colon cancer pretty much every year, and it's gone up. In 2020, there'll be close to 150,000 patients that were diagnosed. Of these, about 53,000, close to 53,000 people died from this disease. So increased awareness and screening would at least save 30,000 of these, 50,000 people that otherwise died last year. So, and the problem is that, with whatever we've got available, 1 in 3 adults who is supposed to get a colon cancer screening is still not getting screened. So it's a preventable cancer that can prevent death, but still, a major proportion of people are not getting screened, which is something that we need to really pay a lot of attention to. So as I said, colorectal cancer is highly preventable and can be detected by testing even before there's symptoms. So it could be an asymptomatic patient, and they still would be able to develop colon cancer without having any warning shots. And there are about close to 1.45 million people that are living in the United States with a history of colorectal cancer, either treated, partially treated, but there's still about close to 1.5 million people that are around there with colon cancer diagnosis. So if you look at when does colon cancer happen in the life spectrum of people, so if you see, it's relatively rare in early years, but it starts to go off, in the mid 50s, and then it really, shoots up, as you age. So just like any cancer phenomena, the longer, the older the patient has been, there's a high risk of developing cancer. But if you break down the 50 to 60 range, this is the time when we start screening for colon cancer based on current guidelines. It dips down a little bit, and then it starts to go up in close to the 60 range. And part of this is that 50 is the age where we start screening for colon cancer. So this is the first test phenomena that we see, is that when people get their first colon cancer screening test, it actually prevents some death early on, which leads to a decline over the next subsequent years. And then if the patients have had polyps, which are precancerous polyps, and if they don't get taken care of, or they miss their follow-up appointments, it starts to go up. So this is the phenomena. This dip is related to the one-time or the first-time screening effect, that people are getting screening colonoscopies. So the death rate goes down, but then starts to go up. So that's historical data. That is, what we've seen over the last, almost the last decade. This is, how things have been. And most of the colon cancer happens through a phenomena, what we call an adenoma carcinoma sequence. So if you have a normal colon mucosa, which is completely normal, then you put in some risk factors related to with time, or genetic factors related to germline mutations. People start having these first hit, second hit phenomena in terms of alteration in DNA, and then that's when people start getting prone to developing abnormalities. So what it moves on is like they go from normal mucosa to mucosa at risk, and this is when they start developing polyps, once they start gathering quite a few mutations in the baseline mucosa, and that's where people start developing adenomas. So adenomas are these polyp tissue growth that can actually be seen in the mucosa or in the lumen of the colon. And if it continues to get bigger and bigger with more mutations over type, wild type mutations, or some further loss of mutations over time, it actually can turn into a full-blown cancer. So 70% of the sporadic cancers in people who don't have a family history, who don't have a germline mutation or family history of a syndrome, they go through this adenoma carcinoma sequence. And that is the key factor behind colon cancer screening. So this process from being normal colon to developing a colon cancer through a polyp situation can take about 10 years. So that is a long time that you can intervene, remove that polyp, which mitigates the risk of future colon cancer development, and you can actually give someone, a cancer-free life. So majority of these people have this sequence that leads to colon cancer. About 20 to 30%, that's a newer phenomenon that we're seeing, which is related to sessile-serrated lesions, which goes through an accelerated pathway, which is the sessile-serrated lesion to carcinoma pathway, which has hypermethylation, and that's a much faster pathway. These are lesions that usually you see on the right side of the colon, and usually are flat polyps, harder to find, and that accounts for about 20 to 30%. But in the majority of these people, you can find a polyp well in advance before it turns into cancer, and you can resect it, and you can pretty much cure it. And that's why, most of the colon cancer screening efforts are directed towards removal of adenomas and sessile-serrated lesions and detection of early stage colon cancer that eventually can have a good survival. So if you look at the trends historically, how things have happened. So we have some data, from the 1930s all the way to early 2020s, that we currently have through CRC database. So if you look, the colorectal cancer incidence and mortality. So the colon cancer incidence, we started doing some sort of a screening for colon cancer in the mid-70s. So those were usually stool-based testing that we started screening people with. And that's, where we saw that, with the use of those tests, there was an uptick in the diagnosis. So most cancers were being diagnosed because we started instituting a test that could actually pick them. And then it started to go down once we started screening them. And we thought that, if we're picking some positives, we got to do something about it. So the screening led to a drop in the incidence of colon cancer and overall mortality of cancer over time, in the mid-80s after the screening had been in play for about 10 years. Colonoscopy really took effect in the early 2000s. Colonoscopy has been out since the late 80s to early 90s, but it was being done as a flexible sigmoidoscopy as a screening test and not a wide spectrum adoption of colonoscopy. But the real phenomena with colonoscopy we started to see in early 2000s when there was a lot more knowledge, a lot more information, a lot more interest towards getting colonoscopy as a screening test. And that led to rapid decline in the incidence and the mortality of colon cancer in the early 2000s or mid-90s, I would say, to 2010, 2012. So that's what colonoscopy can do. So there has been a 30% reduction in incidence between 2003 and 2012 with a lot more widely acceptable colonoscopy intervention. And that was related to increasing screening with colonoscopy. And also, there was more education about, smoking cessation and healthcare behavior modification, that led to that phenomena. But here's the real problem. This is a historical chart between different age spectrum cohorts. So this is the age group, 50 and above was the age group that we traditionally have been screening based on the guidelines. So if you look, from the 1970s to early 2000s, we were successfully able to flatten this line, or maybe, somewhat decline the incidence of colon cancer in this age group, 50 to 54. Similarly, in people who are older, we were able to, there was a downslope in the incidence of colon cancer just because, these are the people that were getting screened. So we were very successful in bringing the incidence of colon cancer down in some of these people. However, the challenge that we're seeing now is this age group, the younger population. Since the mid-80s, this is the group that actually has seen the highest or the quickest uptake of incidence of colon cancer, less than 50 years old. And this has traditionally been the group that we have not been screening. These are younger people. We think that they don't have as many risk factors, but, this is the phenomena in the mid-90s that, from 1995 onwards up until 2012, that there has been an uptake in the incidence of colon cancer in this subgroup, the younger population. And that's going to be the focus, for the next, 10, 15 minutes. So if you look at the trends, 40% increase in colorectal cancer in younger patients, less than 55 years of age, since 1995. So 10 to 15% of the overall colorectal cancer develops in now younger people, which is a pretty big number. It didn't used to be that big, but now 10 to 15% of the cancer that is diagnosed is in people who are less than 50. And rectal cancer rates have doubled in the last 20 years in patients who are less than 50 years of age. So if you attended the multidisciplinary conference that Dr. Lambiase presented yesterday, there was a patient who was only early 40s, 42. So that's the new phenomena that we're seeing, in people who are very young. So if you look at the incidence in age 20 to 49, this graph is starting to go up. The mortality is also, it was flattening and then now starting to go up, based on some of the other, overall trends that it was going down. But this is the group that is starting to peak up now. So this trend is actually in contrast to older age groups, whom the death rates are decreasing by about 1% in the group that is older than 50, and group that is over than 65. There's a sharp decline, 1% and 3%. But this is the group that actually is on an upswing. So that's where the problem is now. So talking about colorectal cancer in young people, why do we think this is happening? There's some possible risk factors since the 90s onwards. There's an uptick of obesity epidemic. The average BMI has gone up, and that potentially contributes to, oncogenesis, and sedentary lifestyle plays big. COVID is partly, something that we can extrapolate. A lot of work from home. A lot of more technology that has come into play. Very sedentary work, has played its part. And then, we don't know about the genetics. There's something which is different in younger population, which cannot just be explained by obesity or lifestyle changes. There is definitely some genetic phenomena that is in play, and that could be related to processed foods. That could be related to some, industrialization, environment, some risk factors that we're getting exposed to. Other risk factors that have also been attributed to younger population, getting colon cancer, red meat consumption is on the rise. Fructose corn syrup use, antibiotic use, and history of IBD as we become more industrialized, that's a phenomena that actually has led to, some increased risk of colon cancer in younger people. So again, another a graph demonstration, this is for people less over 50, and this is for people younger than 50. So the rising incidence is in people who are younger than 50 years of age now. So is it artifactual? Widespread use of colonoscopy is a detection bias. Are we doing a lot more colonoscopy for symptoms that require for people to get a colonoscopy at a sooner age, and we're just picking them early? Is it just because that's why the incidence is going up? It's unlikely to be that case. It would have been very easy to say that it was detection bias, because a lot of people, who have symptoms, are getting colonoscopies at a much younger age, and maybe we're picking them early. But it's unlikely, because most of these cancers in younger adults are being detected in later stages. So it's not that, they've had these lesions or cancers in there for a very long time. The first colon test that they get, even if they get picked up with a colon cancer, it's not that, it's going through a slow process. It is actually a later stage cancer that you're finding. And we find more advanced disease, once you pick that up, even if there's an adenoma, it's an advanced adenoma in those people. And those with stage 3 or stage 4 disease have shorter duration of symptoms to diagnosis. Even if they were symptomatic, their disease symptom to diagnosis progression or pickup was much shorter compared to people in a higher age group. So there's definitely something in play which just cannot be explained by the typical or the traditional risk factors for colon cancer in some of the older patients. So it's not just a detection bias related to increased colonoscopies being done in younger population. So where are we in terms of screening some of these young people? So this is a nice bar chart about how we compare to some of the other Western world. So where do we stand on colon cancer screening in the younger adults for colon cancer screening? So if you look at some of the other countries like, Austria, Italy, and Lithuania, where they actually have been screening younger adults, even for the last, 15, 20 years, they have shown a decline in the annual incidence of colon cancer in this patient population. But, since the US did not have that kind of a built up program as a screening program, we actually had an increase in incidence in this younger population. Similarly, UK, Denmark, Korea, where the screening guidelines were based on age 50 and above, there has been an increase in incidence in younger population. But countries that had adopted colon cancer screening at age 40, they were able to actually reduce the incidence of colon cancer in this age group. So there's definitely a phenomena which can lead to early detection by administrating a test early on and preventing death from that. So that was sort of a lead into as to, some countries are doing it better than us. Maybe, that's something that we need to look into, more. So where do we stand in colon cancer screening as of today? In 2021, where do we stand? So there was a roundtable colon cancer prevention conference that had, all the big minds, sit on a table, and they came up with a goal. We should at least be screening about 80% of the eligible patients by 2018. So that was the goal determined by the roundtable conference, for 2018. 80% eligible adults should be getting screened. Where are we today? So right now, we're close to about 68.8% who were screening. Eligible patients were getting screened, for the age group that is recommended. And of these, 65% are getting colonoscopies, and then, the rest are getting stool-based tests and other forms, which we're going to talk about very quickly. There's several high-risk populations that remain underscreened, and that is probably the group that leads to lower levels of colon cancer screening. African Americans historically have been screened less, and so are the Hispanics. So Hispanic is probably the one biggest group, that is not getting as much colon cancer screening. And there's various factors as to why people don't get screened. Those without insurance, who feel that, it is going to be costly, that plays a big, huge role. Those with limited financial means and access to broader healthcare, people who just don't have access to healthcare, to a primary care physician or any facility that they can actually be able to get a test. Education plays a big role. College graduates have been shown to have a higher level of adherence to colon cancer screening guidelines than people who are not college graduates. Recent immigrants, they're not part of the healthcare safety pool, so that is a big group. And every non-invasive test, that is performed, and if it's positive, is required to get a colonoscopy. But the colonoscopy follow-up to non-invasive stool-based testing also has been very, very dismal. So once you've had a stool test that is positive, you're obligated to have a visual inspection with a colonoscopy performed. But even then, once somebody's had a positive colon cancer screening test, the conversion to colonoscopy remains, close to 60%. So this is where I think, this was a light bulb that went up, last few years ago. Do you guys remember this famous actor? So Chadwick Boseman's death actually reignited the debate. We must be doing something that we need to really pay attention again. He was only 42. He was a Black African-American man and developed colon cancer very early, and he died within a few years of developing that. So that, put people's focus back on that. There's, once it's a celebrity, there's a lot more focus towards it. So it reignited the debate, that, we need to really look at this again. We were just going on with our business, whatever it is. But then, his death really led to a change in, mindset. So his death unfortunately renewed attention to colon cancer screening, and if we need to screen people earlier. And also, it's racial disparities that, he was an African-American Black man, and, if that population is getting screened adequately. So unfortunately, his death led to something that we actually owe to him, has changed a few things in colon cancer screening. So if you look at the incidence and mortality by race, so the highest group that is affected, which is this light green bar, is the non-white, non-Hispanic whites. This is African American, population. So that has the highest incidence of colon cancer. And the white Caucasian, population actually is much lower compared to that, and the American Indian and Alaska Natives, who have the highest risk of colon cancer. So there's definitely some racial disparity in people who are getting colon cancer, and partly that is related to who's getting screened, who has access to healthcare, who's got availability of healthcare facility option. So again, colorectal cancer outcomes. So colon cancer mortality in Blacks went from being 10% lower in the whites in the 70s when we started looking at this phenomena to 50% higher by 2005. So mortality in Blacks actually traditionally, was at par with the Caucasian people or whites. But then, there has been a huge, difference in terms of, incidence, and that is partly in terms of uptake of colon cancer screening has been higher in whites than in Blacks. And that's what has led to, this widening gap between the two. So this racial disparity is in part attributed to a combination of lower screening and lower stage specific survival rates among Blacks that we talked about. There is something at play, which could be genetics, which could be, loss of follow-up. Oh, Dan.
Just a question on that. You're talking about that there's also the Hispanic one.
Mm-hmm.
Why is their incidence lower when they get screened less?
So So in terms of if they're getting screened, why their incidence is higher? You're talking about this slide?
That slide and the other, their incidence
Mm-hmm.
Hispanics report mortality,
Mm-hmm.
even though their incidence of screening is less.
Correct. So Hispanic could have genetic factors, which accounts for that, and I'll talk about it a little bit, I mean, and there's some cultural barriers in terms of, who gets what, as of how things are being done today. But partly, it could be related to the diet. It could be related to, family histories and some of the genetics that the Hispanic population has, that even if they're not getting screened as much, they still have a lower incidence, even if they get screened. So it could be a genetic factor, it could be a lifestyle, it could be environmental factors, that have played into that traditionally. And plus, we don't have a huge amount of data in Hispanics. We pretty much, started collecting data in the mid 90s, about the Hispanic population. Prior to that, majority. So more of the trends that we've seen are related, from colon cancer screening programs that started into the 70s. So from 70s to 90s was, 20 years worth of data. And from 1990s to now, we barely have some data with Hispanics. So that's a population that, we're probably going to have more data over the coming years. So more on racial disparity, by estimation, 40% of the racial disparity in survival colorectal cancer is due to later stage of diagnosis in people who are a minority, more unfavorable tumor characteristics, and more comorbidities, when among Blacks, when they get picked up. So Black patients are also less likely than others to receive appropriate surgery, adjuvant chemotherapy, and radiation treatments based on the studies. And there's different factors that are involved, and we're not going to delve too much into those details. Among those 50 and above, colonoscopies are more likely to be received by people who have a college degree. So people who have a higher level of education, they're more adapt to getting screening colonoscopies. Hispanics in this age group were still less likely to receive colonoscopies, and that's more of a cultural phenomena. Obviously, uninsured had lower rates in all age groups. So where do we stand as in 2021? We talked about that. There's a phenomena which we hadn't seen before. All our screening guidelines had talked about screening patients above 50 and over, but we had seen an uptick in terms of patients who are younger to develop colon cancer. So based on the most current guidelines that were presented by the United States Preventive Services Task Force and all the GI societies, all combined, came up with this unanimous recommendation that we should start now screening all asymptomatic adult patients above 45. So that has fundamentally changed the bar to the left. We were only screening patients 50 and above. And mind you, these are people who have no symptoms, who have no family history. They're just regular people with no risk factors. So these are all average risk factor patients who have no symptoms, no family history. And now we do recommend starting them at age 45. So now this was based on some of the data that we've historically seen, that there's an increased uptake of cancer in the late 40s. And it's a qualified grade B recommendation, meaning that it's a very strong evidence towards that. Now, where are we in terms of starting this? Now, this was a recommendation that just came out in May of 2021. A lot of insurance companies have not adopted that, and they're the ones usually who dictate, who gets what and when. But most likely they will follow the trend, once Medicare approves that as a screening age for 45. Now, beyond asymptomatic patients with no family history, evaluate still all symptomatic adults. Anybody with rectal bleeding, changes in bowel habits, with the weight loss, iron deficiency, anemia, all these people should be screened much sooner than age even 45 if they have any of these symptoms. But the new age for the fundamental change that is that age 45 is the new screening age. And this is based on some of the extrapolations based on models that they've actually seen in terms of cost effectiveness, in terms of, how much we can contribute, by doing this. So if you look at this, what do we gain by starting age 45 screening? So any test that you perform, direct visualization test or a stool-based test, you can actually save additional 26 years of life gained, by just starting screening at age 45 out of 1,000 individuals screened for colon cancer. So that's a pretty decent number. You can actually save extra 26 years by just screening 5 years, prior to that. Similarly, you can prevent 3 additional cancers from happening if you start screening at age 45. You can you can avert 1 death, by just starting screening, out of 1,000 patients. So that's a very decent cost effectiveness in terms of, how much you can prevent by just starting to screen early. So let's shift gears to, what tests are available. So these are the testing options that we currently have. A lot of people think, colonoscopy is the only test available for colon screening, but that's not the case. That's probably the best test, and we'll talk about why. But there are stool-based tests. There's a FIT test, which is antibody reactions, where you're trying to find out if there's any blood in the stool sample. And there's this, fecal occult blood that could be GOAC-based, that is, again, looking for traces of hemoglobin, which is being shed into the colon and then being picked on the stool test. Then there's a multi-targeted stool DNA test, commonly known as Cologuard. That is a new kid on the block, in the last 4 or 5 years, that has been approved. Then there's a flexible sigma endoscopy that is going out of favor. That was a limited inspection of the colon, where colonoscopy is a full inspection of the colon. And then, there's options with CT colonography, which is a 3D construction of a colon, where you can actually try to find a polyp, which is a CT scan. So what are the recommended tests at this time in terms of colon cancer screening? So colonoscopy by far is the most commonly, or the most strongly recommended test, because it is a one-step approach, and we'll talk about why. So colonoscopy examines the entire colon. You can actually biopsy and remove the polyps, which can prevent future colon cancer. You can diagnose other diseases at the same time, and it is required as a follow-up test for any test that becomes abnormal on colon cancer screening. So, plus, it gives you 10 years if it's a negative exam. You don't have to worry about colon cancer if it's a negative study. Then you have computed CT colonography. It gives a visual construct 3D of a colon. It's a quick exam. It has fewer complications, no sedation required, non-invasive, looks at the entire colon, but it's only every 5 years. Flexible sigma endoscopy, where you only look at the left colon, but you don't look at the whole colon. And now we see a lot more polyps on the right side, flat polyps, which quickly grow into colon cancer, is another alternative, which is every 5 years. So these are the tests that are acceptable tests. This is the then this is the test that, is the most accurate test, but these are the acceptable tests. Then there's stool-based tests. One is a FIT test, which is, a stool test where, a chemical antibody looks traces of blood in a stool sample. But that test has to be done annually, but it has the benefit of, no bowel cleansing is required. It can be performed at home. It's a very low-cost test. It's non-invasive. Similarly, GOAC-based test, can be done at home. Same benefits. Again, has to be done annually. Not as good sensitivity compared to the FIT test, which is now the most strongly recommended stool test if you want to perform one. And then there's a multi-targeted, stool DNA test, which is the Cologuard. Again, it's a stool-based test where you mail in a kit, with a stool sample to the company, and then they come back with the result. And it's a multi-targeted test. It looks at the blood in the stool sample, and also it looks at the altered DNA. So it's a 2-step test, which has a higher sensitivity, but less specificity. But it still is under cost evaluation, still being looked at, but it's currently recommended every 3 years. The tests that are not recommended, and this is also another take-home slide that I want people to understand. These are the tests that we don't recommend. So in-office stool tests are out. You do a rectal exam, and we used to, put them in a little stool card, and then, put a little primer on it just to see if it's positive or negative. So that is not a recommended test anymore. So, and that should not be performed. Any test that we need to do as a stool test should be a lab-based test. Over-the-counter toilet bowl tests, which were common, which are GOAC-based tests, that a lot of commercial companies advertise, are not recommended. But their sensitivity and specificity is not that great. Barium contrast enema used to be a test, where we would perform that as a screening test. That is not recommended anymore, based on some of the GI Society guidelines. Some of the blood tests, that are out there, they're being looked in. There's insufficient data at this time to make them as a first-line, test as a colon screening test. And similarly, colonoscopy, capsule endoscopy is not a test that we recommend at this time. So right now, current screening rates, colonoscopy is probably the most widely used colon cancer screening test in whites. A lot more whites are choosing colonoscopy. Stool-based test is still being preferred by a lot more, minorities, Hispanics, African Americans, and still more than 20 million eligible U.S. adults have not participated in colon cancer screening. So these could be, people that are out there not been screened, who could have potentially something, and failure to complete, all this is related to some of the factors listed here. But very important for primary care physicians, it should be a shared decision-making. What kind of a test a patient really has access to, what they can easily get done, and what their preferences are. So if you see someone who's a candidate, you should risk stratify. Do they have family history? Do they have obesity? Do they have other risk factors that puts them at a high risk of having something going on when you talk to them? And if they're high risk to have concerns for colon cancer, you should try to get them a colonoscopy, because that's a diagnostic and a therapeutic test. But if they're low risk, you can go with non-invasive tests. Fit-based tests, stool-based tests are still tests that can be performed. So it does not mean that the only test that they have to go for is a colonoscopy. There's other options available. Now, as we said, there's tests available. You lay the cards in front of your patient and you ask them to choose based on their preferences, based on, what they want. Because the most important thing in colon cancer screening is that they should get screened. So the best test in our scenario is the test that gets done. If a person is hesitant of getting a colonoscopy, but would be inclined to get a stool-based test, go for it. At least you have something that you've been able to achieve. So, it should be based on patient preference, discussion with their provider, the availability of different options that they have. So any test that is non-invasive test, stool-based test, CT colonography, or any form of test that has been performed, and if it's positive, it must be followed by a diagnostic colonoscopy to detect polyps and colon cancer. Now, why that is important? Because colonoscopy is the only test that has both diagnostic and therapeutic capability. It's a one-step approach. If it's the first test that people choose, it has the potential to cure polyps, by removing them and prevent future risk of colon cancer. Observational studies have suggested that colonoscopy can help reduce cancer incidence by about 70% and mortality by 68%. So that is by far the best test that you can do. You have visual inspection, you can mitigate the risk while you're in there. And similarly, adopting colonoscopy at age 45 is looking to be cost effective and also cost saving compared to even the group that is being currently screened at, which is about 40. So in cost effective analysis, this will be an interesting fact for a lot of you. So in cost effective analysis, with current trends that people adhere to in terms of what tests they get, colonoscopy is pretty much as cost effective as getting a fit-based stool test. So we think fit only takes about $15 and colonoscopy could be several $100s. But in cost-effective models, because this gives you extra 10 years of protection, and this gives you annual testing, but still has to be converted into a colonoscopy if it's positive, that both are cost-effective. So if one test that you have to propose to your patient, if they're willing to, should be a colonoscopy because it's a one-step approach. It does not have to be replicated by another test. Okay, let's quickly shift gears to neurotechnology and what's out there, and a lot of this is to do with what we have in pretty much in every field, which is artificial intelligence, deep learning and neuronal networks that we're, trying to make use of. So the next several years would likely see a very rapid development of AI tools in gastroenterology. Pretty much, I think, in every field, Machine learning is a branch of AI which focuses on computer algorithms. So you feed big data to these computer softwares, and then, it's self-learning. The more a computer software looks at, the more pattern recognition it adapts to. So the more you tell them that this is how a polyp looks like, it would be better the next time to tell you, oh, yes, this is how a polyp would look like. So this is where we're moving towards. So a deep learning is an advanced subset of machine learning that relies on specific algorithms that are termed artificial neural network. We're probably going to be, all be, looking into, things that are going to be majorly changed based on artificial intelligence, pretty much every field. So the rationale, for artificial intelligence, adenomatous polyps are precursor lesions. Identification and removal of these polyps is an effective approach for colon cancer prevention. Some colon polyps may not be seen and can be easily missed. So currently we're thinking about 15 to 20% of the polyps could even be missed at expert hands by an endoscopist, people doing colonoscopy. These are so subtle, you can't look at every inch in a corner and you can still miss these. And an aided artificial intelligence tool may help visually identify polyps to improve polyp detection during colonoscopy. So what happens? It's not an alternative to colonoscopy, is an aided to a colonoscopy. So you're performing a colonoscopy, the live video, as you're seeing real life, real time is being fed into a device which is based on artificial intelligence, and that device then processes that information based on what it's looking at, and then actually gives the feedback at the same time back onto the screen that there's something that is being missed, or something that needs to be looked at again. So it's pattern-based technology. It is going to be the future in endoscopy and especially colonoscopy. The first artificial-based intelligence colonoscopy device was approved by FDA based on European data in 2021. But we currently are one of the lead sites for a multinational site on clinical trial, which is looking at artificial intelligence-based technologies in colonoscopy. So this is actually one of our real-time videos, and this is how things look when we had this aided tool on a colonoscopy exam. So you look at that, you're looking at this colon, you don't see anything, and then all of a sudden a box pops up. And, you might have just very easily missed this subtle polyp, but now just because, something is popping up, it's driving your attention towards that spot. When you look at it closer with different kinds of lights and tools that you have, it actually gives you an idea that, yes, there is a polyp that could have easily been missed, So this is where the value of artificial intelligence in colonoscopy. So this is one of the patients that we actually performed, this test on that helps identify more polyps. The more polyps you find, the more you remove them. Once they're removed, you're not sticking with things that have been sitting in there that you've missed that can grow. And plus, that could have led to longer follow-up times in terms of these people. The more polyps you find, more frequently you do the colonoscopies. So one, you're missing polyps that could still continue to grow, and number two, you've missed them, so you have a double hit phenomena that you're bringing them back later if you've missed them. So that helps you in terms of mitigating the risk by removing the polyp, by resecting it at the time. The other active field that is also pretty hot, is endorobotics. You've heard about robots being used in every other field, surgery robots, all of that. So endorobotics is another field, where there's a tiny robot that you can introduce and you can control with a magnetic arm. And that's also a self-guided robot, it's like a little Mars rover that goes into your colon. You can even control it with a joystick. So you can play your video game sitting behind a desk, or it can actually self-learn it and, keep going around based on, the simulation that has been fed into that using a magnetic arm where, it just moves around. And then the newer technology that is looking into this is, they have little channels, just like real robots that surgeons use, where an instrument would come out and it would actually try to remove that polyp. Now we're far from that stage, but the technology is moving towards that direction, where this could eventually become, a pretty popular thing in the years to come. Now all these are aided tools. They would not replace a physician or a provider performing a colonoscopy, because we've not gained that kind of a mastery over some of these. That could be self-sufficient. So that's what I had to talk about today, and I'll be happy to take any questions if there are any. Yes, sir.
Thank you for a wonderful talk. Roomba for the colon, huh? Yeah.
Yes.
Okay, so
actually, one of the physicians in Vanderbilt is one of the pioneers in endorobotics.
So one question about the role of aspirin in reducing colon cancer, which you didn't address. But the second thing, the more important question is, do the cancers in the younger population, 40 and younger, 45 and younger, do they follow the adenoma to carcinoma sequence, or are they predominantly sessile lesions that accelerate faster? And so in the younger population, if you screen earlier, should you also be screening more often?
Wonderful question. So the first question related to aspirin. So aspirin has been shown to be beneficial in terms of preventing colon cancer. The reason why it has not made it to the mainstream guidelines for colon cancer prevention risk is because, our screening population was 50 and above. So those are the people traditionally have higher factors to cause bleeding in. So aspirin definitely has risk prevention for colon cancer, but it is not recommended just because it increases the risk of GI bleeding. And actually can trigger some false positive tests. If you're taking any blood thinner or you're taking aspirin and you're performing a stool-based test, that can increase the risk of a positive test. So it does have prevention data, and it's pretty good in especially men with comorbidity. So Anybody who has cardiovascular risk factors and they're above 50, there's definitely data to support use of aspirin, but it's not a recommended based on guidelines because of the risk of concurrent GI bleeding as well. The second data about younger patients with having non-traditional adenoma carcinoma sequence and maybe having cess-ulcerated to carcinoma sequence, and that is exactly true. So we're seeing more early onset hypermethylation abnormalities, which is the hallmark of cess-ulcerated lesions to carcinoma pathway. So yes, that is the phenomena that we're seeing. Now, cess-ulcerated lesion pathway came to attention about 15 years ago, early 2000s. Still a lot of pathologists are in that learning curve where they're not even calling it a cess-ulcerated polyp. It is a subcategory of a hyperplastic polyp that we used to think was a non-cancerous polyp. But so as we get more knowledge about that, I think, it's going to be the mainstream. And one of the phenomena that we saw based on flexible colonoscopy versus the full colonoscopy benefit is that flexible sigmoidoscopy was not looking at the right side colon. The right side colon cancers are usually the cess-ulcerated lesions-based cancers. And those are harder to find. Those are more flat. Those grow quickly into a tumor, and they're at an area that is difficult to look at. But it's the same reason I think, there's a newer set that may actually exceed or overtake the traditional adenoma carcinoma sequence. It's around 30% cancers are through that pathway. It may become 50-50 over time. There's definitely genetics involved with that. Anything else? Well, if not, we'll conclude here, and thank you so much for your attention. Yeah.